welcome, welcome, welcome to Health Issues. I'm your host, Chris Sylvain, and we have an exciting show for you. It actually fits along with this series we've been doing, actually dealing with addictions and substance addictions and the whole incarceration rate, everything together. But we have an extremely distinguished guest, and we've had Ochsner on before, and we're kind of continuing in that group right now. We have the Chairman of Chemical Dependency Unit of the Psychiatry Department. He's going to share more of the exact, Dr. Dean Hickman from Ochsner Hospital. Thanks so much, Doc.
Thank you for the invitation.
Hey, we appreciate it. So that is the Chemical Dependency Department?
Correct. I have the Addictive Behavior Unit at Ochsner Clinic,
Okay.
and it's, for the most part, a partial hospital program where we treat people with chemical dependency problems for approximately 4 to 6 weeks on an intensive outpatient basis.
Awesome, awesome. And a psychiatrist.
Correct. I'm a general psychiatrist as well.
General psychiatrist. That's fantastic. When we look at the idea of addictions, and we're going to speak particularly about heroin addiction, and I'll give the background. What it was, we had Dr. Representative Joe LaPinto on a couple of shows ago, and basically he indicted the medical community in a sense, saying that because of the scourge of the heroin problem, particularly in the state of Louisiana, that they felt they had no other choice. They advanced the bill, and I'm not sure where it is in the legislature now. They advanced the bill using the criminal justice system, the prisons, as a place to handle heroin addicts, because the medical community has not been able to step up to the plate. So anyway, let's talk about, he brought in a number of cases as far as for the reasons why, and let's talk about it. One of the reasons why, he said, was that it's cheaper at $24 a day to put somebody in prison as it is to send them to a hospital. Your thoughts?
Well, I don't know about the cost of hospitals versus prisons. What I would say is we're talking about short-term treatment would be much more cost affordable than long-term incarceration, particularly when you look at some of the sentences that have been given through the years, including life in prison. I mean, that's a very expensive proposition, I would think.
That's an easy one. Exactly. Very, very good. Now, also, you mentioned about detox, whereas prisons were the perfect place for them to inpatient treatment, so to speak.
Mm-hmm. Well, detox is a short-term solution to a problem, and certainly it's a very big part of chemical dependency treatment. But detox, we're only talking about 5 to 7 days of detoxing someone, say, off heroin or opiates. Ideally, after that, what you need is a follow-up and aftercare and continuation of therapy, whether it's counseling, but you also may need residential housing as well. People that are kind of strung out on these drugs don't have many resources whatsoever. There's no employment, there's no place to live often. So there's a whole host of services that would come together to properly structure a treatment program. Recently, I read the governor of Vermont spent his entire State of the State address this year, you can Google it, on heroin addiction in Vermont. And we think of a state of Vermont, it's got the 5th lowest unemployment rates in the entire United States.
Really?
It's a pretty pristine place to live. And yet his entire 34-minute speech was about heroin, opiates, what it's cost Vermont. 80% of the incarcerated people in Vermont are there because of drug or drug-related crime. Okay,
well, is there a capacity, though? Say if the legislature decided, okay, we're going to shift these people over to hospitals or non-criminalized treatment. Is there capacity to handle it?
I don't think there's capacity with the structure of medical resources as there are today, but certainly if you invested money, particularly from the federal government, into concerted treatment programs, aftercare programs, residential treatment programs, those are very successful. We have a couple nonprofit programs in the state, particularly in the city. You have Odyssey House here, which does some short-term detox. It also does some residential care. Bridge House does an excellent job with residential care. Mm-hmm. So the models exist. We just need the federal government and the state to fund these programs.
So real easy, just shift some money from the prisons and move it over to treatment, and it's better.
I think that would be the more cost-effective approach. I don't think you can jail your way out of this heroin problem.
It makes sense all the way around. Even today, though, that argument, we've had people from the state on over and over again, the so-called mental health crisis in the city. I've asked, and we've done shows on it, and we don't really see this idea of lack of beds. Over and over again, I keep hearing that if there's somebody with a mental health issue, a substance abuse issue, all right, they're not being turned away. Somebody's finding a bed for them. They may have to not go to this facility, but go to that facility. But when the state checks the beds, there's usually some bed that's available. Have you found that to be true?
I wish I could have that phone number for those beds, because every night I have people sit in my emergency room with psychiatric or drug-related conditions whom I don't think we can release safely, but they need a bed, and they tie up our emergency room department space.
So, hey, that's we're going to have to pull the state in again, because we keep hearing opposite information. Period. You've just said it. There aren't enough mental health beds, even with all of these DePauls and Turo and all of these other facilities, that they're full.
Turo may have some geriatric beds, but it doesn't have any acute general psychiatry beds.
Acute general psychiatry beds.
None.
And so even the Metropolitan Health District says that they had capacity, or whatever the name is. Judge Calvin Johnson was a part of that group, but so there's just no beds.
I have people 24/7 that have a complete list of hospital beds in Louisiana that call 24 hours a day trying to find beds for people that are sitting in our emergency rooms and cannot get a bed.
So for every legislature that would be the state, and I think the city would have to say something about that. So therefore, point closed, we need beds, and so tax dollars need to be spent to get the beds.
Many years ago, there was something called the single point of entry. So if you call the Orleans Parish Region for a mental health bed, they would assist you. I don't believe that program exists anymore. So it forces my emergency department to just start calling for hospitals down a list. I would love if the state would give us a phone number that says they understand the resources, they know where the beds are. One call, they can help us.
Okay, granted that was, it wasn't that long. It may have been a year or more ago that we dealt with the state with this issue, but we've asked over and over again. So money needs to be spent for beds, and that includes for heroin addiction. So if somebody's addicted to heroin, again, it would be cheaper, though, to put that money into a hospital bed at any hospital, whether it's a for-profit or not-profit institution. And I'm surprised that there's not enough Medicaid money coming in for for-profit institutions to create beds.
No, I have not seen a single chemical dependency bed created in probably 20 years. We've lost them, not created any.
So there is not even any insurance money available for somebody to create one, so to speak. It's a money loser, so to speak.
Correct. There's not enough insurance allowed treatment to have even for-profit centers wanting to get into the business. Insurance companies are very rigid. As soon as the person is medically cleared, within a few days, they want them out the hospital from a detox perspective. So even the insurance industry is not helping our problem, because they're so rigid in applying their criteria as to who needs to be in the hospital. Okay, so and many would be men that wouldn't be eligible for the Medicaid dollars. So therefore, we're looking at maybe Obamacare, and that takes so long to get somebody signed up. So for the most part, since we're dealing with many men, it's not women with children. Literally the insurance industry, we're kind of wiped out there, other than dealing with just pure federal dollars. You know, I haven't seen the impact yet of the new health care reform as to whether that's going to create more demand. You would hope it would create more demand for services, because it now is mandated to include substance abuse treatment, as opposed to some private insurance companies didn't have to offer mental health insurance or substance abuse years ago. Okay, so capacity is not there. So that's one. Doesn't mean it right, moral, correct, or anything else like that, but that still has to be debated. But that point is correct, that attempting to use prisons to treat, and let's go to the next, the bigger issue is that how is it that we've criminalized something that's a disease? Well, I think it's an easy way to get out of it if you're in a certain arena and you're desperately trying to approach this problem. But the American Medical Association has said for over 50 years that chemical dependency and alcoholism is a drug disease, is a medical disease. You can understand the effects of it, you can quantify it, you can see it, and if left untreated, is a fatal condition. Just like obesity. Correct. So people, and I say it all the time on the show, we have people that are addicted to Coca-Cola, we have people that are addicted to cocaine, we have people that are addicted to heroin. Who gets to decide which one becomes criminalized? Correct. Yeah, I mean, it's still, yeah. I mean, so. think people that find themselves with particularly narcotic addictions put themselves in a desperate position. The intensity of withdrawal from heroin or narcotic addiction, while it's not life-threatening, is very uncomfortable. It's nausea, vomiting, diarrhea, intense leg muscle cramps, intense abdominal muscle cramps. Those patients don't want to exist in that state, and they're going to go off and satisfy their drug habit, and if they have to steal, rob, that's what it takes to do it. That increasing desperation increases the risk that they're willing to take to do that.
Okay, let's go down the list. Let's look at the withdrawals and the obviously we're laying out the withdrawals as a propensity to possibly steal to support a habit, okay? All right, let's line up with, I guess, let's start with alcohol. How much different are those withdrawals?
Okay. Alcohol withdrawal is life-threatening, so it can create seizure activity, it can create stroke, heart attack, just because the blood pressure rise, the heart rate rise. So it is a medical emergency sometimes in alcohol withdrawal. But alcohol is very cheap in that if you need to satisfy that withdrawal, you can do what you can to get a few nickels together and share a bottle with a friend.
Grab some vodka and you've solved your immediate
problem temporarily.
That's
correct.
right, because I remember working in a prison where they didn't have alcohol. That's when withdrawals was a life-threatening issue, because but if they just gave them some vodka, it would solve the problem.
Correct. Or they have great medication management treatment.
Exactly.
So when I see somebody in the hospital with alcohol withdrawal, it's very easy to treat. We give them appropriate medications, and it prevents anything like seizures or complications.
But so therefore, alcohol withdrawal is more severe, but you don't have the propensity to steal. All right, let's move up to marijuana.
Mm-hmm. Marijuana is an uncomfortable withdrawal, but it's not very life-threatening. It's not very uncomfortable. It's often sometimes you have intense nausea with it or vomiting episodes, but in general, you just feel a psychological need to want to go achieve it again. So I don't really know any marijuana patients that take high risk to go support their habit that way.
Okay, cocaine.
Cocaine's similar to marijuana, more addictive in terms of it creates more that psychological need to want to use. You're kind of burnt out, you're fatigued, you're just tired, and you feel that you need to get that extra hit of cocaine to get back and functioning. And there is some criminality involved in paying for cocaine, because it is much more expensive than, say, alcohol. But it's not as much as that desperate need to get that fixed, to take the large chances often.
Take the large chances, all right. So that pretty much, and I'll go back now. Intentionally, I wanted to wait Coca-Cola near the last. People who are addicted to food, Coca-Cola and those types of things. Let's say if we had a prohibition against soft drinks.
Well, I think you have to look at any addiction process, including even pathological gambling. But
okay.
People that have poor eating habits,
right.
You want to look for underlying conditions, whether it's medical or psychological. You want to give them relapse prevention behaviors. When you're in this mode, do you tend to eat? Are there triggers to eating certain high calorie foods? What other lifestyle changes can they make? Can they exercise? Can they sleep right? Can they create short-term goals, long-term goals? Are there support groups that we can put them into? So again, I think we have an obesity program at Ochsner. It's also very successful. It involves some surgical procedures that we can do now, but in large part that's been very successful. But patients have to change their lifestyle. And that goes back to the drug problem, in that detox beds don't fix that. Detox beds only fix the short-term uncomfortable part, but you have to be taught the relapse prevention techniques, the goal-setting strategies that many of these people have not been able to do for themselves.
So if we look at the whole gamut of the entire group, heroin is the sole one, heroin and alcohol, that has the detox issues involved. But outside of heroin and alcohol, it's not a whole lot of detox that's needed. So if we take the detox component out, is there a great deal of difference between the treatment from, say, marijuana, alcohol, cocaine, food, heroin?
No, I think there isn't a great deal of difference on the back end of it.
On the back end.
It's aftercare. Patients in our program typically spend 4 to 6 weeks, Monday through Friday, in an intensive outpatient setting. After those 6 weeks, we put them in our aftercare program. Okay. They go to a weekly 1-hour group therapy meeting. They have an individual therapist that they may see weekly for a while, then twice a month, and then maybe monthly. In addition, they're consistently going to their 12-step meetings. Alcoholics Anonymous, Narcotics Anonymous, those programs are just invaluable to us as part of our armamentarium as to how we approach chemical dependency or any addiction.
Any addiction. And success rates. You know, not necessarily
rates,
numbers.
Sure. I think success rates nationwide are abysmal in that there's not as much focus on the aftercare component of treatment. That when I have patients from all walks of life with different motivations. When I have a patient that's been referred by his employer for testing positive for drugs, those patients do exceedingly well in my program, in their aftercare program. I deal with men that have maybe a 9th grade education, but they make $70,000 a year in a highly trained, dangerous job. They understand they're not going to risk that job again, and I've given them the tools not to risk that job. So depending on individual motivations and encouragement, it can be very successful.
Yeah, it varies with the success rate, I understand. So when we look at heroin, though, and we carve this particular drug out, again, other than the detox program, is there any other reason to carve it out?
Well, detox alone doesn't fix it. What you see right now is that many of the people coming out of jail with heroin addictions who have been in jail for, say, years, they're dying on the streets of New Orleans right now because they've lost their tolerance for heroin, and yet they go right back to try to think they can use the same dose again. So even though they've been clean and they've been detoxed for anywhere from weeks, months to years, it didn't solve the problem because they didn't get the treatment necessary to make the necessary changes in their lives to avoid the relapse.
So therefore, we go right back again. Using penal institutions, criminal institutions, from a medical standpoint, would you say is no advantage, worse, or better?
Well, I think for the better cost of society, it's not an advantage. Building prisons costs money. That money is taken away from other resources that could be used to enhance treatment. You have people in Angola right now that in the 1970s were probably heroin-dependent patients themselves, or people themselves, that started to deal a little bit to support their own habit, and yet they ended up in prison for the rest of their life, probably under a law that was designed to get drug kingpins. Very few drug kingpins got sent to Angola for life. It was a lot of street-level dealers that had addictions themselves. So, I mean, you have people now that would probably have done well to reform their lives, et cetera, but they're not in a position to get out, and we're still paying for them.
Question then. Again, that whole gamut of substances that's taken within the body, that the body intends to literally desire a very, very strong way. Is there any one of them? How do we quantify the ones that are worse?
Well, I think it goes to brain chemistry. Narcotics and opiates pose a special problem to us because we have certain receptors in our brain that are designed to perfectly match to narcotics and opiates. When you have pain and you're in an emergency room and we give you 50 milligrams of Demerol, the pain goes away pretty quickly. Think of my hand as a brain receptor, and an opiate fits perfectly into that. And once that receptor is used to having that opiate on a chronic basis of 6 to 8 weeks, then it demands it. And when it no longer has that opiate inside that receptor, it becomes a very uncomfortable situation that starts in the brain and then moves to the rest of the body. Other drugs so far don't have specific receptors in the brain that fit like a lock and a key, and that's why narcotics pose a particular problem in addiction.
But and I'll throw the one out that seems to create so much trouble, and is marijuana. Third offense, you end up with 20 years in prison. Where does marijuana fit in that scheme?
Well, we haven't isolated a particular a particular receptor in the brain for marijuana. We know that marijuana is a very fat-soluble drug. The brain is largely composed of fat. So some people like to exist under the influence of marijuana. The effect lasts for a while. It's in their brain. It goes throughout their central nervous system. But there's not a specific receptor. Therefore, when they don't have marijuana, the withdrawal is not as severe.
The health of an individual, then, the mental health, physical health, holistic health of an individual, if we look at out of these substances that are probably most damaging to the short-term and long-term health of the individual, how would you say rate them?
Well, certainly heroin would probably be at the top in terms of the substance itself causing death. That the fine line between what a drug user uses for a high versus what can kill them is sometimes very narrow, particularly depending on the purity of heroin. So if you're buying from one guy and he gets a different supply, or he cuts his drugs with a different substance, you could end up with something 6%, you could end up with something 90%. You don't really know. That's the danger point of heroin, in that many overdoses are caused because people don't have the capacity to test for the purity of the heroin that they're injecting in their system, or they misjudge their tolerance. Often you find heroin addicts dead with a needle in their arm. I mean, they die that quickly. They go to sleep, their brain loses oxygen, and the rest of the body takes a vengeance when you don't give it oxygen.
Wow, and they were having trouble executing people. Interesting. But all right, so let's kick heroin out. Okay, that one's done. Now we have the rest.
Well, and prescription narcotics are very similar to that.
Okay.
You have some other prescription medications, sedatives, Xanax, Valium. We haven't talked much about them, but they also are very similar to alcohol. So Xanax, Valium, Ativan, that's a drug that also has a medically dangerous withdrawal that can be lethal in withdrawal. Not as lethal in overdose, but it can be, particularly in combination with other drugs, including narcotics. Very lethal in that case.
Okay, good.
Cocaine, again, you're looking at short-term effects of cocaine. You can see stroke, heart attack, those kind of things. We see that. We see infections from people injecting drugs. Heart infections are particularly becoming more common in intravenous drug users right now. Okay, marijuana, you're not necessarily going to die of a marijuana overdose. What we're seeing right now across the country, including Colorado, is the motor vehicle death is rising 300%. Because more marijuana is out there. People are driving under the influence. As I said earlier, it's a fat-soluble drug. You don't have great control of your motor skills at that point. So that's become a real problem with the marijuana users, is their driving capabilities.
So, but is there, I mean, as you're speaking about this is awesome information, because is there a scale that determines, we can look at other drugs, risk-benefit ratio. I mean, that's how drugs are put on the market. Right. But when we look at these illegal drugs, I've never seen a scale that rates the risk-benefit ratio or whatever, the high as opposed to the damage associated with it. And I think it has huge societal implications.
You're right. It has short, intermediate, and long-term implications. So for marijuana, while you're not going to see somebody die of it, it certainly has long-term complications, including your ability to excel at school, your ability to excel at a job, because of the fat-soluble nature of the drug. Many of the drug users know that marijuana is not going to get out of their system for 2 to 4 weeks or so. Well, that has a cognitive component to it, particularly when you're doing fine job-related, detail-oriented type jobs.
Now, all right, and we go to cocaine, and I'll throw it out. Who's to say on a long-term basis, risk-benefit ratio, that marijuana is safer than cocaine?
I couldn't say that. You couldn't say that, because marijuana itself is a drug still under study. We know that there are probably 278 components of marijuana, the largest being tetrahydrocannabinol. But there are 200 other drugs that we have yet to really fully understand what's the impact. You see patients now that have smoked marijuana for long term. They certainly have chronic obstructive pulmonary disease, like nicotine smokers do as well. But I just see a large impact, particularly in that 30 to 35-year-old age group that have been smoking for a long time, and they look around, they're at a position in life where they didn't intend to be, that they kept putting their goals, aspirations off, and they've not been able to achieve that in many cases. And it's hard to play catch-up when you're 35.
Not advocating cocaine, but cocaine actually works as the opposite. Cocaine, people are sharper mentally, they're faster, they're quicker, they're stronger. Not the down part, but on the up part.
On a short-term basis, you could see that. You could see it's a more attention-creating drug that I'm not advocating it for short-term benefit, but this goes back to Sigmund Freud, who thought that cocaine was going to be a really good drug for the treatment of depression and various conditions.
It was in Coca-Cola.
It was in Coca-Cola. But Sigmund Freud himself became a cocaine addict and dysfunctional at that point and later in his life. So cocaine's a very destructive drug in the long term, correct.
Well, the point of it is that with legislatures across the country deciding to move marijuana to a legalization standpoint, Louisiana's not moving that way, but the discussion is out there, but nobody's asked you guys.
No one has come to me for an opinion. I know there's other people in the community that have voiced their concern, but their concerns were not solicited. They just sought to voice their concerns. No,
I have not heard a professional in anybody's newspaper that they have asked to rate these drugs to decide what you've just said just now. I have not heard it. As far as I'm concerned, marijuana makes you dumb, and it's the dumbest drug anybody could ever take. It's hallucinogenic. Why would somebody legalize a nutty drug like this?
You know, when I ask many people and patients about the case in Miami where the gentleman ate the face off the other person, I said, what drug was he taking? They all say he was on PCP, angel dust. In that man's autopsy, the only thing found in his system was marijuana. That was the only drug found.
Period.
Now, not many people have that much of a violent reaction to marijuana.
Right.
But it affected 2 lives, obviously, that day.
Literally, it makes you dumb. I mean, it's a dumb, I mean, people they're out of it. They lose attention. They could like it, whatever they want. But if they, I always said, if they shouldn't pick any, if they were going to pick one, to me, cocaine is at the top of the list. Now, again, not advocating it. I'm just from a medical, my thinking, even with the dangers, but to pick, no, none of them. But still, the only reason it's such a big issue is because of the criminalization of the product.
Right. Now, young brains are developing up until about age 25. You're born with a certain number of brain cells, but those brain cells have to make connections, and those connections are not going to happen till you're 25. And what I've told my 2 teenagers are that I'm never saying that you can't drink, you couldn't use a drug, I'd rather you not, but at least wait till you're 25. Let your brains fully develop. Let them achieve the full potential that you have, and then you decide if you want to screw it up with drugs or alcohol. And unfortunately, many people in our society don't wait, and they do screw it up. And I think there are problems that they see later in life that they could achieve more, could have done more, could have been a better thinker and process their talents a little bit better.
What about just being free? Not bound by substances.
Absolutely. The word addiction comes from a Roman word for enslavement, that it really started with a financial debt that you owed someone, and you became addicted to that person until you paid off your debt. And yet that's the very thing that we see today, that addiction is just another form of enslavement with patients.
People are literally, and again, in this modern society, there's substances everywhere. And I make the point, and we don't have to go there, and we have a lot of time, we'll come back again, but this whole concept of food, and I keep having to throw that in, because the criminalization of these substances, but then we have tons of other substances in the supermarket that are also damaging to the human system, that people are getting heart attacks, strokes, and cholesterol raising from.
The cost of obesity in America clearly is in the billions in terms of what we all pay for the health care of others that need so many medical treatments. You could walk in any hospital in America, and unfortunately over half the people in America are in a hospital right now because of an unhealthy lifestyle choice, either narcotics or alcohol or food or lack of exercise. It's unfortunate, but we're all responsible for the most part of our illness as we age.
Enslavement. I don't even know if we have a few seconds, but the idea, and you guys, what you do is help people break from slavery.
Absolutely. I give them my best advice. They can choose to take it or not. What I never tell my patients as they see me years later, I never say I told you so.
Be free. Chris Sylvain, Health Issues, Dr. Dean Hickman. Call your legislature. Tell them, call the experts. Quit trying to do something they don't know what they're doing. They're backwards, losing their mind, trying to destroy a whole operation in the whole city. That's from me, Chris Sylvain, not Dr. Dean Hickman, but stay strong.